29th June. The slide seminar will be of infective diseases of the brain by Dr. Anita Mahadevan. She is professor, Department of Neuropathology, NIMHANS, Bangalore. So let's start. I invite Mukta ma'am to start her presentation.
The format of this lecture, as you must be knowing, is that we have a few slide seminar cases and we have some students. So what I will do is I will have some introductory slides about the GI polyps, and then I will begin with the cases. I will ask the students to describe the histomorphology and if they can arrive at the diagnosis, and along with them, anybody can answer these questions also, of course, online. To test yourself, and then we will have some closing remarks. And we are fortunate to have Dr. Prachi Patil, gastroenterologist from Tata Memorial Hospital. She would have her inputs regarding what all this means. You know, as pathologists, we make all these efforts, make the diagnosis, learn morphology, blah blah blah. But what is the real clinical impact of all this diagnosis that we learn? And that is what we would learn from Dr. Prachi Patil, maybe in between the talk as well as at the end of the talk as well. So there we go. Okay. So we shall begin with very basic concept of what is a polyp. What do you mean by a polyp? So let us understand that when we say this, it just means that any lesion that is raised above the mucosal or skin surface, right? So underlying cause can be diverse. So a polyp can look like this, or it can even look like this, okay? A pedunculated polyp or a sessile polyp, but anything that is projecting above the surface of either the mucosa or the skin, both such projecting out lesions are called as polyps. And we can have numerous reasons for having such projections above the surface of the mucosa and the skin. They can be as diverse as beginning with inflammatory conditions, then they can be hematomatous conditions, then they can be neoplastic conditions like adenomata or carcinoma as well. And every type of polyp has got different clinical connotations with respect to the diagnosis at our end as far as the pathology goes, and also the management of that patient who has that polyp. Histology diagnosis is mandatory in cases of the histology, in cases of the polyps of the intestine. So coming to the polyps of the large intestine, pathologists play a critical role in management of the polyps because they have to answer two questions. What is the type of a polyp? And the second question is there a malignancy in this polyp? Okay, and we have to answer these questions in context of the endoscopic findings, in context of how many number of polyps are found on endoscopy, what is the location of a particular polyp. And remember one thing, what I'm again driving at is, earlier I said that there can be diverse etiologies of the polyp. So that also means that not every polyp seen on endoscopy is an adenoma. And an adenoma, we will talk about this, is that by definition is a neoplastic condition. So by definition, a polyp doesn't equate to an adenoma all the time. And just for example, I have collated these 4 different images wherein the colon has multiple polyps. And Dr. Prachi is with us. I'm sure with her experience of so many years of endoscopies, she would be very good in distinguishing one condition from the other. Here we have one FAP, which is one of them. We don't know. Prachi would be able to say that. Then one of the conditions is a case of ulcerative colitis with inflammatory polyps. So a condition which is completely different from that of FAP, familial adenomatous polyposis, wherein you get numerous polyps which are carpeted on the mucosa of the colon, whereas the other condition is completely benign, which is an inflammatory condition. Then we have some hematomatous polyps here. We have some lymphoid polyps. We do not know what is the nature of the polyps is, whether they are neoplastic or no. So Prachi can chip in at this moment or maybe even later. But the issue remains is that the gastroenterologists are getting better and better and better with the advances in the endoscopic techniques like the narrow band imaging, blue light imaging, the eye scan enabled endoscopies. And it is based on the basis of endoscopy is a clear visualization of the microvascular architecture and the surface structures of the colorectal polyps. And this architecture makes the gastroenterologist enabling the different characteristics of different types of polyps. So Prachi, would you like to say something about this at this moment? Or would you keep your comments till later? Prachi, can you hear me?
I think Prachi ma'am is not there.
It's not there.
No, not there, ma'am.
Right. Okay. Maybe we can revisit this slide because I'm very sure she would be very quick in diagnosing these conditions. But in spite of that, the fact remains that we have to have the biopsy diagnosis to document the further management of each patient. And remember, not all, this is just an example that I'm giving you to tell you how good the gastroenterologists are getting at the endoscopic diagnosis, but not obviously all the patients would have such polyposis, or not all patients have multiple polyps. There can be just a single polyp which would be given to you for diagnosis. And here comes the classification of the colonic polyps, and this is also applicable to other GI tract as well. A polyp, it can be neoplastic as well as non-neoplastic. Neoplastic polyps could be epithelial or non-epithelial. Okay, and we will come to that. Non-neoplastic polyps could be hematomatous. They could be inflammatory, reactive, or reparative. So this is a simplified classification of colonic polyps. The epithelial polyps, on the other hand, they can be conventional adenomatous polyps or serrated polyps. The conventional adenomatous polyps can be either an adenoma or adenocarcinoma, and the serrated polyps have their own host of classification, which we will eventually come to. So let us begin with case number 1. And with the help of these cases, I will just elucidate what all types of polyps we have in the GI tract with their morphology. So the major emphasis today would be on the morphology of the polyps. I will not be talking too much about the genetics and the IHCs and everything, but it is going to be morphology. So this is a 65-year-old male patient with bleeding per rectum. Colonoscopy, we found a pedunculated polyp which measured 2.5 by 2 into 1.5 centimeter in the sigmoid colon, which was excised and given. So this is the histology. So can the first student, Shreyans, can you take this case up, please?
Yes, ma'am. The micrograph shows a low power view of a colonic structure. It is showing polypoidal structure with a stalk containing fibrovascular core in it, and there is the amount of villus component is more in the micrograph, both micrographs. The fibrovascular core also contains blood vessels, and one part of the polyp is showing cribriform architecture glands in it.
Okay, so do you want me to go ahead?
Yes.
Right. So as Shreyans correctly said, we have a polyp here. Okay, and it is pedunculated. That's very important. And why do you say it is pedunculated? Because we can actually see this stalk, and this polyp begins here. After the stalk ends, the polyp begins. At this power, Shreyans, can you say whether what kind of polyp this could be?
Ma'am, on appearance, it's on the left side it is showing villus arrangement.
Villus arrangement.
And, right side there is villus plus glandular arrangement also. So it can be of a tubulovillus type. Ma'am.
So no. Before even that, epithelial polyp, or do you think it could be hematomatous or inflammatory?
No, ma'am. If it was hematomatous, it can be showing arborizing muscle fibers in between.
So that's okay. So it is a pedunculated polyp, which is most likely to be epithelial type because it has a lot of tubulovillus architecture. Yeah, but now that doesn't really mean that it is epithelial polyp. We'll see what it means. So now we will move ahead. Now what I have pointed out is this is the stalk or the peduncle. That Shreyans correctly said that it's a pedunculated polyp. So let us see what the peduncle looks like on higher mag on magnification. Shreyans, what can you see at the peduncle?
Ma'am, on left side, it is showing a stalk with polyp arrangement, and polyp is having increased amount of glands which are appearing normal
I am not telling you to go higher up on the actual polyp. We are still at the stalk here. Yes. And I have magnified the epithelium that is lining this stalk. What can you see here?
Ma'am, the glands are normally appearing, which are having nuclei which is basally placed, and the stroma is containing lymphocytic infiltrate along with blood vessels, and the glands is having some mucin in their lumens.
So is this normal or abnormal?
Ma'am, on right side it's showing a normal glands arrangement.
Correct. So the stalk of the this pedunculated polyp contains or is lined by completely normal colonic mucosa. Right? And that is what is shown here. This is a completely normal benign colonic mucosa, and the actual epithelial polyp really begins where the stalk ends, and that is here. Okay, so this is actually the part of the normal colon, which is kind of, you can say it is displaced because of this huge polyp, but the stalk is always lined by normal benign colonic epithelium. Now let's move ahead. Now this is the part of the polyp. Somewhere maybe, I don't know which part it is, but somewhere say, for example, here. Okay, so Shreyans, what can you see now?
And there is a elongated glands are seen. And it's having a different size and shape of glands, which are having a hyperchromatic nuclei and a scant cytoplasm with maintained polarity. And in stroma, there is a lymphocytic infiltrate with blood vessels is seen, and glands of the lumen is filled with the mucin.
Here.
In this also,
this is the same focus, but still higher magnification. Now, all I want to focus on is we just saw this as a normal mucosa, which was present at the stalk. And I want you to compare the nuclear placement. Okay, they are, first of all, the glands are all geometrically symmetrical. Yes. Okay, they look like flowers when you cut them transversely because they are simple tubules which start from the surface, end on the muscularis mucosa, And hence, when you cut them in longitudinally, they would look like parallel test tubes. On the other hand, if you cut them transversely, they would look like nice geometric pattern of, say, flowers. Okay, so that's the overall view. Then the nuclei are basally located, which are looking like these small blue dots at the base, at the basement membrane. And these are small nuclei without any loss of polarity, without any nuclear chromatin enlargement, no nucleoli. So this is an absolutely normal gland and with no dysplasia. Here is the gland which is showing no dysplasia. And now, once you start saying, as you correctly said, they are starting to show dysplasia. And why can you say can you say that? First of all, see the geometric arrangement is lost. The glands are irregularly placed. They are of irregular shapes and size. They are bigger than the normal gland that we just saw, and because they are containing more chromatin, because they are dysplastic. And this dysplasia is evident based upon this increased blueness as compared to what you just saw as a normal gland. It's very blue looking, isn't it? Yeah,
Yes,
but don't get fooled by just the blueness. It can be a pitfall because if the basal glands are cut in a tangential manner, you might see blue nuclei. So now this is the gland. Now, can you see the stark difference between the normal glands which we saw and these glands? What is
yes,
the difference?
yes, ma'am.
I want you to highlight this because this is what would be a defining feature for any adenoma. Okay, so normal versus presence of dysplasia is the key to the diagnosis of an adenoma.
Yes, ma'am. It's showing, ma'am, branching pattern and tortuous glands are seen, and loss of polarity is seen, along with the stroma containing blood vessels and lymphocytic infiltrate, ma'am. And
I think you are you don't focus too much on the stroma or the blood vessels. I think we should concentrate more on the glandular features and the their nuclear features especially, because that is what is going to tell you whether this given polyp is an epithelial polyp and is it dysplastic or not, and that would then be equivalent to the diagnosis of adenoma. And then is a matter how much is the dysplasia, the low or high. But first, let's get it correct that indeed this is a dysplasia. That is the first step, and I'll just tell you what are the features to look at. First of all, the sizes and the shapes of the glands. They are irregular glands. They are very, very large glands because they contain lots and lots of chromatin, which you can easily identify by the blueness of the glands. Then coming to the individual cells, there is a loss of polarity and stratification. You remember how those nuclei were basally located, very small, very, very regular. And look at these, there is stratification. Too many of those cells are existent in a single gland. Okay, so the nuclei cannot accommodate themselves, and their polarity, meaning one nucleus is down, one is above. So they are not just basally located. So that is loss of polarity. Now, what can you see as far as the shape of the nucleus is concerned? They are elongated.
Yes.
Elongated
pencil shaped nuclei.
Correct. Then that is the third important feature. So, that they are elongated as against basally located in the normal gland and as against the rounded vesicular nuclei in high-grade dysplasia. There are very, very tiny nucleoli. There aren't too many large nucleoli, and they are hyperchromatic, blue-looking chromatin. Okay, and
Yes.
can you see too many mitosis here? I cannot see. Could you see? There might be occasional mitosis, but there aren't too many of the mitosis.
Yes, basal mitosis is increased, ma'am.
Yes, but not very brisk mitosis.
Yes.
So what does this become? Can anyone tell you? Is this a dysplasia or not?
Yes, ma'am. Yes, ma'am.
Dysplasia. Correct. Absolutely.
Low grade dysplasia.
Low grade dysplasia.
Let's come to that. So once you say dysplasia, what are you committing to?
Epithelial.
Epithelial one and second.
Uh,
Epithelial can also be sorry.
Tubular adenoma, epithelial.
Yeah, adenoma. You know, the moment you say it is dysplasia, there is a dysplasia in an epithelial polyp, it becomes an adenoma. Okay, so that is the defining feature of an adenoma. An adenoma cannot exist without dysplasia. It is a complete paradox. Okay, so far your diagnosis is it is a pedunculated epithelial polyp with dysplasia. That means it is an adenoma. Now the next job that you have in hand is to classify it further as to which type of adenoma it is. Okay, it is pedunculated, fine. It has got lots of villous components, so it is a villous adenoma. And now the next job at hand is to say what degree of dysplasia it is. So these features, what we just talked about, do they amount to high grade or low grade dysplasia?
Low grade dysplasia.
Low grade.
Right?
Low grade dysplasia.
Low grade dysplasia.
Exactly right. So remember this, there are certain paradoxical features in the form of hyperchromasia, okay, where we can see in low grade dysplasia. But when it comes to high grade dysplasia, the nuclei become round and vesicular. So pencil shaped nuclei, loss of polarity, hyperchromasia, not too many mitosis, disorganized glands, all these amounts to low grade dysplasia. Right? So is this morphology clear?
Yes.
Right.
Yes, ma'am.
Okay. Oh, okay. So we had another of the image. Look at this, a very crowded gland. Then stratification, pencil-shaped hyperchromatic nuclei, and I don't see too many mitosis in this field. Maybe one or two, or maybe not even. So this is a classic low-grade dysplasia in an adenoma.
Yes.
Any questions so far?
No.
So this is yet another part of the same adenoma. And okay, so why I took this picture? There is a part of this stalk here which is normal, and then this is dysplasia. Okay, that comparison becomes very important. And then in a given biopsy, if you have normal colonic mucosa, make the most of it. Do not ignore, because that becomes your basis of the morphology to compare your abnormal findings. Right?
Yes.
Okay. So now moving ahead to this is a tubulovillous adenoma which is pedunculated. Now, Dipali, can you take over next? Can you see anything more in this adenoma?
Yes, ma'am. Yes, ma'am. In this section, I can see there are glands which is having a stratified lining and with the pleomorphic hyperchromatic nuclei. And
No, can you move ahead, Dipali? We already decided that this is a tubulovillous pedunculated adenoma with low-grade dysplasia. Now, I'm highlighting some other finding here with this arrow. Can you focus on that?
Yes, ma'am. This is suggestive of some invasion and stromal invasion, and the neoplastic glands are pushing the pedunculated stalk.
Okay.
So there is some stromal invasion, and most probably muscularis mucosae layer is invaded, and the lamina propria and submucosal.
First of all, why are you calling this invasion? So, do you think this is an adenocarcinoma?
Ma'am, adenocarcinoma, carcinoma, if we call invasion, then carcinoma will be there.
Higher power. And the reason I'm showing you higher power is, Dipali, focus on the architecture of the tumor. See, this is the
tripliform architecture is there.
Yeah, it is getting so disorganized, isn't it?
Yes,
compared to this part of this is a tubulovillous adenoma that we just saw. So compared to this architecture of the polyp, this is getting so disorganized. You are having lobules, okay, of dysplastic epithelium, which are very disorganized as compared to the superficial part of the polyp, isn't it?
Yes, ma'am.
Yes. And they are also forming small buds. They are breaking off. So you are quite right. This is an invasive adenocarcinoma arising in a tubulovillous adenoma. Correct?
Yes, ma'am.
Yeah. So now see these small glands which are invading here. They are so unlike the part of the tubulovillous adenoma that you just saw. Do you agree?
Yes, ma'am.
So
I have one question.
Till what? Yes.
Ma'am, could this not be pseudo invasion? Because
No, this is not a pseudo invasion. The reason is that the glands are very distorted.
Yes.
Okay, we can see single gland invasion here. The glands are actually containing necrotic material. They are breaking down in this image. Very, very distorted. In see, I mean, today I haven't included any pseudo invasion, but when there is pseudo invasion, the glands would carry the lamina propria with them. Okay, and they would show retained lobular architecture. Those are the keys. Here, there is a complete disorganized way of invading the submucosa through muscularis mucosa. So this is not it. See these glands. They are like, literally single glands are breaking off these disorganized architectures. So this is so your diagnosis becomes
tubulovillous pedunculated foci of adenocarcinoma.
Okay, I would
carcinoma in tubulovillous adenoma.
Right. That's right. Very right. See, what the more significant finding here is finding of an adenocarcinoma. So always start with adenocarcinoma arising on the background of the tubulovillous adenoma with low-grade dysplasia. Right, that will become your diagnosis. Tubulovillous adenoma with invasive adenocarcinoma. Now, at this point, let us just learn something more about epithelial polyps. So, this is a conventional colonic adenoma. And when I say conventional, that means by definition, it has presence of dysplasia. Okay, read the last line. By definition, they are dysplastic. The dysplasia might range from mild to severe, or the term that we use now are low or high grade dysplasia, but they are dysplastic by definition. You do not get an adenoma without a dysplasia, right? It is a paradox, and you should never make such statements in your reports. So this is an unequivocal neoplastic alteration of glandular epithelium. It is an irreversible phenomena. It is a part of adenoma carcinoma sequence. I mean, this adenoma, once develops, knows how to grow and how to grow even into carcinoma when a certain point reaches. Okay, so till it forms an invasive adenocarcinoma within it, it is still considered to be a benign neoplasm, but a neoplasm. Okay, it is a neoplasm, and by definition, dysplastic. So we have three histological types: tubular adenoma, tubulovillous adenoma, and villous adenoma. We just saw an example of a tubulovillous adenoma. So proportion of villous component has significant correlation with malignant transformation, and villous adenoma are generally larger in size. Let us move to case number 2.
Excuse me, ma'am.
Yeah.
There's a question in the chat box asking, can we call it Cushing glands?
Can we call it
Cushing glands?
Oh, okay. So same question as Shreyans asked. That Cushing glands means pseudo invasion are synonyms. So I already told the reasons why it is not pseudo invasion. Yeah, there is a disorganized growth. The glands are breaking down. There are single gland permeation, and then there is a reaction into the around them instead of presence of lamina propria. Okay.
So, madam, just a few comments.
Yeah.
Yeah. So one thing is that I think it's also the endoscopist's responsibility to give the pathologist all the required information in the endoscopy report.
Yeah.
So it's important to see how many polyps have been found on endoscopy. So the number, the site, and what is the size of the biggest polyp. So a good endoscopy report should mention all this, and also the age of the patient, because it gives you a little bit of a clinical perspective about what you might be looking at.
Correct.
Also, some things in the endoscopy report that could help you is that typically on visualization, mucosal polyps are going to be divided into pedunculated, what Madam showed just now. Then there would be sessile polyps which don't have a stalk, which are flat, and then there's a mix of the two, what is called as PS. So they'll give you an idea about what is the morphology of the polyp, and if we do remove a pedunculated polyp, ideally we should be inking the base so it's easy to identify. Because sometimes the stalk is short and then the cut is very much near the head, so you don't really have enough of a stalk to identify.
Correct.
Which is not correct, because you might be cutting through a dysplastic part, and that's not good for the patient. So you must insist on the base of the polyp being inked, and the base, the polyp ideally being mounted and sent, especially for big polyps.
Yeah, absolutely. That's a very, very important issue. And yes, endoscopic findings are invaluable. In fact, we should not begin to diagnose the polyp without endoscopic findings.
Yeah. And also, I think now we would prefer not to send you biopsies really, because biopsies might be non-representative. Like you showed the polyp just now. I mean, not all parts are equally bad.
Yeah.
So there could be a sampling error. So now small polyps ideally should be removed completely, mounted, and sent for a pathological evaluation. And only if it's a big polyp where there would be some risk in the endoscopic resection, would you want to take a few targeted biopsies and then send it to confirm the diagnosis so that the treatment is planned.
Correct. So you're saying, Prachi, that most often we are actually getting the excised polyps, right? Where we add the margins as well.
Right. And although I'm saying it, I know that even we fall short of mounting them adequately and sending them to you, but that's the ideal that we should try to target.
Yeah.
Because otherwise, frequently, it's difficult to make up the base also, isn't it?
Yeah, it is very difficult, and especially when cautery is used, it just curls up. The base curls up. So it is very important that it is inked at the endoscopy room. Otherwise, it would curl up even further, and we wouldn't really know where the base is, and we would miss out on our important.
So a polyp that's resected completely and mounted helps the endoscopist know three important things in the report, and one is the morphology. Second is the base, whether it's involved or not. And third is the depth of submucosal invasion, especially for big polyps, because we know the depth of invasion correlates with the risk of lymphatic spread, and therefore a local excision may not be enough. Yeah, that's
Thank you, Praj. So can we move toward the next case?
There are a few more questions related to this case in the chat box. So should we take it now or towards the end?
Can we take towards the end, looking at the time we have in hand?
Yes, ma'am.
Because otherwise I'll be spending too much on one case and there may not be enough time for the others.
Sure.
Yeah, okay. So case 2 is endoscopic mucosal resection of a rectal polyp, and the patient this time is 65-year-old male. Okay, so Anamika, can you take this? This is not a very difficult case to diagnose, but there are certain stark differences between case 1 and case 2. Anamika, are you there? Or can we go to Tushar? Is Tushar there?
Yes, ma'am.
Yeah, Tushar, can you take this case?
Yes, ma'am.
Yeah, let's go ahead. So now describe exactly the way we described the earlier so-called polyp, and let's arrive at the diagnosis and go in a systematic way.
Okay. So the picture one, there is a section shows multiple polypoidal structure without any stalk, and there are predominantly.
There are only two. The
Yes,
polyp has been divided into two and submitted. So yes, you said something important. What did you say?
And polypoidal structure without any stalk.
Without any stalk, exactly. Yeah, that's the first big difference between the first case and this case. Okay.
Yes, ma'am. And it predominantly show a tubular architecture with a few dilated cyst-like spaces.
Right. So can you guess what kind of polyp this could be in the rectum? Like we just said, epithelial, neoplastic, non-neoplastic. And in neoplastic, is it an epithelial polyp, non-epithelial polyp? Can you say something about? Can you guess?
Yes, ma'am. This could be epithelial polyp.
Yeah, correct. Because you are seeing all these tubules here and then some villus architecture as well.
Yes, ma'am.
Isn't it? So most likely to be an epithelial polyp. So to further classify it, what would you require?
To further classify from the epithelial polyp, ma'am, I have to see the architecture, whether it's a villus architecture, tubular architecture, or tubulovillus architecture.
That here, you can see that there is a small proportion of villus architecture. Most of it is tubular. So for the further typing of the polyp, what do you need? What assessment do you need to make? What did we just discuss?
Now we have to see the kind of dysplasia it presents with.
We have to go on a higher mag and decide whether there is dysplasia or not.
Yes, ma'am.
Okay, that is our next step. And the further step is to decide the degree of dysplasia. And the further step is then to decide whether there is any invasion or not. Okay, this is the stepwise approach to any given polyp. So now I am giving you the higher mag. So Tushar, can you describe this?
Yes, ma'am. There are crypts with a complex architectural pattern. There are crypt reforming,
Yeah.
and the glands have the glands are lined by epithelium.
You have something normal here at the bottom here.
Yes, ma'am.
Yeah,
There
and compare it with this.
Yes, ma'am. There are areas of normal colonic glands, and also there are majority of the areas show glands with complex architectural pattern. There are crypt reforming of the gland
Correct.
with the micropapillary projection from the epithelium. The covering epithelium shows cytological atypia. There are
Can you see atypia? I cannot see. All I can see is the description that you just made of the architecture, and all I can say is it's very blue looking compared to the adjacent epithelium. I need to go on higher magnification now for further assessment of the nuclei properly. Okay. Now I'm magnifying this portion of the polyp here for you. What can you see here? Again, right?
Again, ma'am, there are areas of normal colonic mucosal glands,
Yeah.
and ma'am, predominant areas of glands with complex architectural atypia, with a few glands showing dilatation and elongation along with angulation.
Correct, and very blue looking. And then there is something which is happening here at the bottom of the polyp here. Let us see what that is. Now I want you to say what kind of cells are these. Are they dysplastic or no? So as I said, that is the next question. Are these dysplastic?
Yes, ma'am.
No, and why?
Yes, ma'am. They are dysplastic, ma'am.
Tell me the reason.
Because, ma'am, the covering epithelium, the nuclei of these are not basally located. There are stratification.
Yeah.
And there are few areas with mitotic bodies.
Yeah.
And also, ma'am, there are, as I mentioned already, stratification, and also there are, because of this proliferation, there are epithelial fragments into the lumen.
Right. Okay. So here the nuclei are hyperchromatic. They are stratified. They are filling almost the entire cytoplasm of the cells. And here they are pencil shaped, but then they are changing their shape in the other glands, wherein they are becoming rounded. You can see necrosis in some of the glands, and it is a very irregular cribriform architecture. So things are not looking good. Okay, very, very cribriforming, which you do not see in low-grade dysplasia. So as soon as you are seeing such architectural distortion, you should be very worried about having a high-grade dysplasia. Okay, this is the image that I was looking at. Now, see, would you say that these are pencil-shaped nuclei?
No, ma'am, they are round.
Correct.
No, ma'am, now they are round to oval with conspicuous nucleoli.
Yes, that's absolutely right. And you are seeing mitotic figures here. Okay.
Yes, ma'am.
And you see hardly any cytoplasm because the nuclei are becoming so big, they are occupying most of the cell. And they are no longer pencil-shaped, elongated, but they are getting rounded. And paradoxically, because of chromatin clumping, the many of these nuclei are looking empty. And that is the meaning of the word vesicular. A vesicle is a bulb, right? Which is an empty bulb. These are paradoxically looking empty because the chromatin is getting clumped. Because as the degree of dysplasia increases, the chromatin amount increases and it clumps. So all these features, in those earlier case, I showed you how low-grade dysplasia looks like. Compare that visual impression with this, which is a unequivocally high-grade dysplasia, wherein you have cribriform architecture, you have high NC ratio, you have vesicular round nuclei as against pencil-shaped nuclei, you have nucleoli and mitotic activity, and also an additional feature of necrosis. So all these features are to high-grade dysplasia. Okay.
Yes,
right. So what is your diagnosis so far?
Ma'am, adenomatous polyp with high-grade dysplasia.
Right. So now at this point, I will say do not use the term adenomatous polyp. You should say this is a tubulovillous adenoma with high-grade dysplasia. This is the correct terminology. Never use the term adenomatous polyp. Okay, that is not the correct term. The correct term here in this case would be tubulovillous adenoma. You can add the word sessile tubulovillous adenoma with high-grade dysplasia. That is your diagnosis so far. So now, next, Arun, can you actually add to what are there any additional findings that you can see here?
Yes, ma'am. Like at this magnification, like as previously said, I can say two different zones. One is highly packed dense glands, and the other area which is showing some normal architecture. But to comment more, I need to go into higher magnification. Like at this point, I cannot say anything. But yeah, few areas of necrosis can be seen on the.
Correct. So as against these glands, which although they are compared to normal, they obviously are distorted and cribriforming, but there is some more anarchies happening here. You can see that the glands are going down, and just like the adenocarcinoma which we saw, this is even worse. Yeah, there are these glands which are invading down into the submucosa. Okay, so this is an adenocarcinoma which is arising from this tubulovillous adenoma with high-grade dysplasia. And then Dr. Prachi just told you that they would resect the polyp along the mucosa margin. And what can you see here?
Ink margin can be seen.
Of course. So the ink, if the gastroenterologist has inked it, we have to reinforce that ink, and this is how it will be seen. But more than that, what can you see? What if the ink wasn't there?
Like the glands going like invading towards the submucosal.
No.
Micro artery.
You can see on cautery artifact
Yeah,
along this
cautery
line.
artifact.
That means that this is a resection margin of this particular polyp. Yeah.
Okay.
So even if there wasn't an ink, that is another way of identifying where the cautery has been made, and which means it is a resection margin.
Okay.
Now, I'm again, do you require, Arun, do you still require higher power to make the diagnosis of adenocarcinoma?
Yes, ma'am. Like
Part of the adenoma, and all this is completely disorganized invasive adenocarcinoma. I thought it was pretty obvious, so I don't think I have a higher mag of this. What I want you to comment on is what is happening to this resection margin in this figure, in this image.
it's trying to breach. The tumor is trying to breach towards it.
Yeah.
It's invading, trying to invade the underlying structures.
Absolutely. So in this image, this particular cauterized margin was away from this invasive adenocarcinoma. But in this figure, this is the second section. What is happening? The tumor is actually involving the cauterized margin, isn't it? That is what is an important finding in this image. So the answer again, let us sum up, Arun.
It is a sessile tubulovillous adenoma.
Yeah.
And dysplasia is a high-grade dysplasia.
Yeah.
And we can see invasion, which is any other finding. It's an invasion can be seen. So it's an adenocarcinoma which is arising from a sessile high-grade tubulovillous adenoma.
Tubulovillous adenoma with high-grade dysplasia.
Yes.
And you missed out on what is
Invasion.
Tumor is involving the
receptor margin.
base of excision. That is such an important finding.
Yes.
Isn't it? And
yes.
First, further management of the patient would depend upon whether the adenocarcinoma is there or not, and if it is completely excised. So now this is what I'm just highlighting this in the higher power again. This is adenocarcinoma. See how irregular these glands are, and they are lined by similar dysplastic glandular epithelium. Here, Arun, so you wanted to see the higher mag. I think I only have this image, but more than showing the morphology of the tumor to show that this is involving the excision margin.
Okay.
So now coming to the issues of malignancy arising in an adenoma, it is a difficult management decision. The next obvious question is, should the surgical excision of the colon be done if invasive adenocarcinoma is reported in a colonic adenoma? Okay, and there are these situations where the surgeons would then, the patient would then be referred to the GI surgeons, and they would resect the underlying colon when the adenocarcinoma is poorly differentiated, whether there is invasion of the vascular space, and whether invasive adenocarcinoma is within 1 millimeter of the base of excision. Now, there are a lot of practical difficulties in assessment of base of excision. As Dr. Prachi has elaborated a few of them, but we face a lot of difficulties where the polyp is fragmented. Okay, you don't know where the polyp is, the base of excision is. It is so fragmented that you cannot orient it. In that case, maybe you can just leave it up to that adenocarcinoma is seen, but you cannot assess the base of excision. And additional prognostic features that are present in any adenocarcinoma arising in an adenoma is what is the depth of invasion, whether there is any cribriform pattern. If these features are present, then there are more chances of involvement of the base and more chances of revision surgeries. Right? So here is a very famous diagram which tells you that this is a pedunculated polyp, like our case 1 was, and this is a sessile polyp, like our case 2 was. And these are the levels. Okay, these are the levels. Level 0 is in the mucosa. Level 1 is into the superficial submucosa. Level 2 is at the stalk. This is the level of involvement by adenocarcinoma. Level 3 is at the stalk. Level 4 is at the level of submucosa. Right? So then these levels become very different when it comes to sessile adenoma. We cannot really apply these level 1, 2, and 3 because there is no stalk. And therefore, whenever there is invasive adenocarcinoma, in a sessile adenoma, it has a worse prognosis. That is because this adenocarcinoma has a direct connection to the main wall of the colon. As against a pedunculated adenoma, if the carcinoma is arising here, as we saw in case 1, okay, it still has to traverse to the stalk and then go to the main wall of the colon. But as we saw into this case, which was a sessile polyp or an adenoma, this adenocarcinoma involved the base and it has a direct connection to the main wall of the colon. So the adenocarcinomas arising in sessile adenomas have the more propensity to involve the colon, and these patients are more likely to undergo revision surgeries.
Madam, just one comment.
Yeah.
So just to explain the endoscopic terminology. So this case, what you mentioned right now, was mentioned as an endoscopic mucosal resection, EMR. So yeah, typically when we say an EMR or a polypectomy, what we do is we will inject a colloid with a contrast like methylene blue dye into the submucosa to lift the polyp. So the plane of resection in an endoscopic mucosal resection is it should ideally be the upper part of the submucosa. You may not actually get a submucosa when the specimen reaches you, but that's supposed to be the plane. So you're supposed to have a very thin layer of submucosa in the resected specimen. A better type of resection is what is called as an ESD, or an endoscopic submucosal dissection, which is actually like a surgical dissection in the submucosal plane, where you're also supposed to get a decent part of the submucosa along with the polyp. So I would also request everyone to pay some attention to what type of excision was done, whether it was a polypectomy, which generally means an EMR, or a ESD. And these are typically applicable for sessile polyps. For pedunculated polyps, typically one would like to have the plane of cut midway between the stalk. So there should be some amount of stalk that is there in the specimen and some amount of stalk that's left behind, mainly because the thicker the stalks are, the higher they bleed. And if you have some stalk left behind, it gives you a safety margin to grasp something should there be a bleed.
Okay, that's great. That's great. So at the same time, because as we just said, the stalk is lined with normal epithelium. So when this stalk rises above the surface, it also carries the submucosa with it. So it carries the muscularis mucosae here, and when the muscularis mucosae is breached, the tumor goes into the submucosa. That in fact is the part of the stalk of a polyp. Then such morphology does not exist in a sessile polyp. Okay, so let's move ahead with the gross handling of the polyp. So Dr. Prachi has just discussed the significance of the status of the the resection margin. So in a pedunculated polyp, we have to block the base of the polyp first. And after that, we have to cut this polyp into three parallel sequences and submit everything through into the paraffin block. Right? So we have this block separately, this block of the cut margin separately, and then the part of the polyp separately, which contains the block as well. When it comes to the sessile polyp, we do not have to block the peduncle because it doesn't exist. So what do? We ink the entire base, and then we divide this, or we cut this polyp into 2 or 3 or whatever number of sections that this allows according to its size. So this is how both are handled separately or differently. So when it comes to the pathology evaluation of polyps resected on endoscopy, this is the information that should be included in the report. The polypectomy specimen should be properly oriented. Sandeep, there is some noise that is coming in the background. Can you just request everybody to mute themselves, please? There is some voice which keeps breaking in.
Actually, ma'am, it's clear. No one is. Everyone is muted, I think, ma'am.
Okay, then fine. So after proper orientation and after grossing, you document if the polyp is sessile, pedunculated, or fragmented. We should decide what is the type of the polyp, neoplastic, non-neoplastic, epithelial, type of epithelium. If there is dysplasia, diagnose an adenoma. And if it is an adenoma, decide the degree of dysplasia and also decide the pattern, whether tubular, tubulovillous, or mixed. Then if there is an adenocarcinoma, then you diagnose an adenocarcinoma and decide about completeness of excision. The presence or absence of invasive malignancy is very, very important. And if malignancy is present, we just discussed what are the parameters for revision surgery. If they are there, you have to communicate it to the gastroenterologist so that further revision surgery can be done. So those are distance from the base, presence of angioinvasion, the depth of invasion of the malignancy, and the differentiation of the tumor. These are important factors that have to be documented. This is a very, very important point because this polyp, for example, this second adenoma was in the rectum. And if this patient will definitely undergo a revision surgery, which will be in the form of, can anybody tell what surgery? If it is in the lower rectum, surgery would this patient undergo?
Colectum.
What? It's in the rectum, lower rectum.
Abdominal peritoneal resection.
Yeah, so it would be abdominal peritoneal resection where there are high chances, if it's a very low rectal tumor, that the patient would lose the sphincter. Sphincter. So it's patient to undergo an APR. So that is why the significance of reporting and carcinoma in the polyp is. Let's move quickly to case number 3. We already are at 8 o'clock, so we have to move fast. So see, this is a very important topic, and I wanted to spend time on this because I wanted to drive across certain points as to basically what is a polyp, how do you define an adenoma, what is a dysplasia, how to differentiate high and low grade dysplasia, and how to handle a polyp grossly. If there is a invasive adenocarcinoma, how to report that particular case. These are the important summarizing points that I want to convey, and these are the common situations that you encounter into your everyday practice in the general hospital. So these concepts are very important. Okay? Let's move, and now we'll go a little faster. So case 3A, this is a 1.5 centimeter polyp in a descending colon, and this is how it looks. Can Kruti take it up, please? Can you describe?
Ma'am, it is a low polyp.
Kruti has not joined.
She did not. Sarath is there.
Ma'am. Yes, ma'am. Right side, I have seen 2 figures. Biopsy from the polypoidal structure, which is lined by columnar epithelium, and I have seen the few dilated glands in the mucosa, lamina propria, sorry. And in low power view, these few of them are normal and few are dilated, and I think mucin rich.
Yeah.
White color, not blue.
Oh, yeah. And this architecture, infoldings.
Infoldings and branching type, boarding type. I also seen.
Called as, what is this architecture called as? Serrations. So this polyp is showing us serrations. And do you think that, like the adenoma, adenomata that we just saw, it resembles the adenoma? Is there any dysplasia here?
In low power view, I don't think focally at the left.
This is the higher mag. Now you can see basally located nuclei. There is some crowding, but no nuclear enlargement, no pencil-shaped morphology. And the cells, there is this infolding, the so-called serration that you can see. Yeah. So this is not an adenoma that we looked at earlier, whereas this is a serrated polyp. Okay, a class of serrated polyp that we're looking at.
Yes, ma'am.
And what does this become? This small polyp with serrations. What is your diagnosis?
I think hyperplastic polyp.
Hyperplastic polyp. So yet another condition which is very commonly seen in the endoscopic practice and which we see almost every day. But the key diagnostic feature here is that the cells, the glands are larger than normal. They have these serrations in different stages of development, and then the cells are very large. They are filled with mucin, and the reason is that they are hyper mature. They have accumulated a lot of mucin within them. Diagnosis is this is a morphologically distinct group of colorectal neoplasms. They represent an alternative molecular pathway to colorectal cancer, and these are serrated polyps. Okay? So serration is a defining histological term, which is a sawtooth glandular architecture. It is commonly seen in hyperplastic polyp. Earlier, they used to be called as metaplastic polyps. So remember this morphology. This is what we call serrations, right?
Yes,
Sharad, so you are familiar with this morphology?
Yes, ma'am.
Yes.
Serrations. Usually, ma'am, hyperplastic polyp has serration above only upper third of the.
Yeah, they're not so well defined. They're not so well defined. So there are other serrated colorectal lesions which are classified as such according to WHO 2019 classification. So they begin with, it is a spectrum. They begin with hyperplastic polyps, which are of two types. Then we have sessile serrated lesion. Then we have traditional serrated adenoma, and we have a serrated adenoma which cannot be classified. This is the classification of serrated polyps. So coming to hyperplastic polyps, they have narrow straight crypts, and they have normal distribution of the proliferative zone in the base of the crypts, and there is uniform maturation with serration, as Sharad correctly said, towards more of a top part of the polyp, and it is towards the lumen of the colon. Okay, these are further classified into these two types. So this is a normal crypt where the proliferation occurs at the base of the crypts, and when the proliferation happens, the cells move onto the top along these lines, and then they die, and then they are shedded off in the lumen. But when a serrated polyp happens, the basic abnormality is the ability of these cells to mature, ability of the cells to move upward, and the ability of the cells to die as well. So as a result of this, what happens is these cells keep accumulating. They are not dysplastic, but they keep accumulating, and they become mature, they become hyper mature. And that is why, to accommodate so many cells, the glands develop these so-called serrations. And because they are hyper mature, they have abundance of mucin. So that becomes a morphologic clue for us to call them serrated lesion. And then just like in an adenoma, we have to classify these lesions further as to, is it a hyperplastic polyp, is it a sessile serrated lesion, or is it a traditional serrated adenoma, etc., etc. So this is an example of a hyperplastic polyp. Okay. Now,
one question. Sorry, ma'am, is this a microvascular type or globulate cell rich type? Can we distinguish?
More like goblet cell type.
Goblet cell rich type.
Yes, this is not a microvesicular type. It is rare. Most often we see a goblet rich. And then they have a different molecular basis as well. As you know, I mean, this is a vast topic in itself. We are not going to cover all that. So we will just talk about the morphological application. So next is clavius TB. Now this time it is appendicectomy. Okay. Now let's begin again with Shreyans. Shreyans, can you describe this?
Then section study shows high power view of a appendicular mucosa, which having elongated crypts in the mucosa and intact muscular mucosa with dilated glands, and a few of them having a convoluted border, appearing as sawtooth appearance.
Yeah, excellent, very good. And then you made a very important point that submucosa is retained. And if it was obliterated, what was your differential diagnosis?
LAM. Low-grade appendiceal mucinous neoplasm.
Very, very good. So this is submucosa is retained, it's not fibrous, and you are seeing these proliferation of glands, which are obviously not normal. They are showing abundant mucin within the cells. There is this serration, sawtooth appearance within the lumina. And then can you see this abnormal pattern? This boot-shaped pattern, horizontal growth pattern of these glands. Here also, these are so-called boot-shaped growth pattern, which is not seen in the normal gland, right? So this image, Shreyans, what is it showing?
Ma'am, it is showing glands, elongated crypts with maintained polarity. Normal nucleus is seen, and there is an abundant amount of mucin in between there.
Correct.
And yes.
And then infoldings in form of serrations. So two important points here, which Shreyans had just made. There is no dysplasia, and then the tumor is showing serrated morphology, right? So there is basally located nuclei and hypermetals with abundant of mucin.
Yes.
And now it's actually looking like two boots. Yeah, these are looking like boots, right? So this is a horizontal growth pattern of a gland, which in itself is abnormal, right? So next, move to the sessile serrated lesion. So this time we are seeing it in the appendix. These lesions indeed are more common on the right side. They are sessile and often covered with mucin. They are difficult to detect by endoscopy because they are literally clouded by mucin, and their resection is also difficult because of their sessile nature. It is a difficult resection, which Dr. Prachi would tell us. So going by the differences, now this is a normal crypt maturation. When it comes to sessile serrated lesion, the cells not only proliferate upwards but also downwards, and that gives rise to these boot-shaped or L-shaped distorted crypts. Okay, so this is a step ahead of the so-called hyperplastic polyps, where you had only one-sided movement, abnormal movement of the cells, but here it is both ways, upwards as well as downwards. And that is a sessile serrated adenoma in the appendix without dysplasia. Right? That is, so now this is a misnomer. We no longer call them sessile serrated adenoma. We call them sessile serrated lesions
without dysplasia.
That is the correct diagnosis. Okay. So the diagnostic criteria are at least one of the following histological features. That we should have horizontal growth along the muscularis mucosa in the form of L-shaped or inverted T-shaped crypts, which we had in this case. Dilation of crypt base. We again had this serrations extending into the crypt base and asymmetrical proliferation, and presence of at least one equivocal architecturally distorted serrated crypt is mandatory for the diagnosis of sessile serrated lesions. And we get dysplasia in around 4 to 8% of sessile serrated lesions, and these lesions are commonly MSI high. Okay. So the next is traditional serrated adenoma. These are the next step in the spectrum of serrated lesions. These are left-sided lesions. They are much larger polyps compared to SSLs, and they have the overall protuberant growth pattern. They have elongated villiform projections, and they have, by definition, just like the conventional adenoma, these also have unequivocal dysplasia within themselves. So these are serrated lesions with dysplasias, and this is a difficult diagnosis to make because many of the conventional adenomas can be confused with the TSAs. So unless we have unequivocal serrated morphology, we do not diagnose a TSA or traditional serrated adenoma. This is one such example that we had. This is our adenoma with very conspicuous tubulovillous villus architecture, but there were conspicuous serrations. You can easily make out that there is high-grade dysplasia here. So this was a traditional serrated adenoma on the left side of the column. These are driven by BRAF pathway. And the importance of serrated pathway is that these constitute a huge amount of almost 40% of colorectal cancers arise via this pathway. And this is an initiating event where the activating mutation is BRAF gene as against the KRAS or the APC gene mutation in the conventional adenoma carcinoma pathway. So it is a totally different pathway. It leads to, it is supposedly a spectrum which begins with hyperplastic polyp, then SSLs, then the TSAs. And the carcinomas can develop very, very rapidly into the polyps. And the underlying mechanism of MLH1 gene. Right? So we will not go into the details because this in itself is a very, very big topic. So let's move ahead. Prachi, at this
Madam,
moment,
just one quick comment. So sessile, as you serrated polyps, as you said, they are very pale as compared to the conventional adenomas on endoscopy. So the conventional adenomas, the more dysplastic they get, higher the grade of dysplasia, they become browner on imaging. So they are very easy to spot to trained eyes, and they are darker. But the hyperplastic family of polyps are paler, typical cloudy appearance, and they are more flatter than the conventional adenomas. So that's why they are easily missed on endoscopy unless you are really looking for it very diligently. And a lot of the missed cancers, despite a normal reported colonoscopy, are now thought to be serrated polyps that were missed and that have now taken the serrated pathway to come out. So I think it's just a matter of awareness that for a long time everyone thought they are just like the hyperplastic polyps that you don't need to worry about it at all. Because the conventional hyperplastic polyps, there are actually now societies that say that if they are small and they are few in number, you can just remove them and discard them. You don't even need to submit them for a pathological analysis because they are very, very harmless. But it's not true for serrated.
That's right. That's right. And actually, I wanted your comments on this, that most interval cancers in the screening population happen via serrated pathways because they develop really, really fast. And in India, we are not into the screening policy for colon cancers, but in countries where it matters. So the next case is a large pedunculated polyp at ileocecal junction. Deepali?
Yes, ma'am. Ma'am, in this section, I can see this section shows the histology of a polyp composed of glands lined by mucinous epithelium, and it is showing the arborizing pattern of arrangement in which smooth muscle is showing infiltrating the mucosa and giving some tree-like appearance.
Yeah.
And at this power, I cannot appreciate any dysplasia and no necrosis or any granuloma seen.
Why do you want to mention about granuloma here? I think you described it very well, that this is a branching tree-like architecture. And obviously it is an epithelial polyp, but you do not see any obvious, blueness. And you want to go on a higher power, this is a higher power. What can you see here? I think.
Ma'am, here also I can see the arborizing pattern in which smooth muscle intersecting with the lamina propria and other connective tissue. And here the glands are there lined by mucinous columnar epithelium, but no dysplasia is still appreciated.
Correct. Very good. So what kind of polyp do you see? Do you think this is?
At this stage, I can see it is hematomatous polyp and favoring Peutz-Jeghers polyp.
Yes, excellent. Very good. So the key features of hematomatous polyp are that you do not get dysplastic epithelium as a defining feature. You don't get dysplasia. The epithelium that is present in an hematomatous polyp is similar to the mostly the organ or the segment of colon or intestine that it is arising from. And then the typical arborizing branching tree-like pattern. So this is the higher power or the higher mag of the component of the epithelium. And can you now see how different it is as compared to adenomata that we saw earlier? And also the hyperplastic polyps. This almost looks normal, isn't it?
Yes.
Yeah,
Yes, ma'am.
that is the peculiarity of hematomatous polyp. So this is a Piyush Jagar polyp, which Dipali, well done. So that's a very good diagnosis. It is a Piyush Jagar polyp. They are hematomatous. Means what does that mean? That they are epithelial indeed. They are epithelial polyps, but they are non-neoplastic. Not like adenoma. Adenoma is a neoplastic lesion, right? So these are common in small intestine in syndromic setting. Microscopically, there is a central core of smooth muscle which branches in a tree-like fashion, and these are lined by benign glandular epithelium, which is similar to the part of bowel where it has arisen. And dysplasia, it's not like you do not get dysplasia in a PJ polyp. You do get, but it is uncommon. And the lamina propria also appears normal in the Piyush Jagar polyps. Okay. Now there is a definition of a polyposis syndrome that goes by the number and etc. And then there are certain other features of Piyush Jagar polyposis syndrome as well. Now I came back to this figure again, Prachi.
Excuse me, ma'am. It's 8:15. Just a reminder.
Okay, great, fine. So I'll be faster. Let us move to this image.
Just one comment about the Piyush Jagar's polyp is that the syndrome, the patients are at high risk for developing multiple different types of malignancies, both GI and out of the GI tract. But it's important to remember that the colorectal malignancies don't typically arise from the polyps. So the polyps are going to be relatively harmless. They're going to mainly cause symptoms like intersusception or bleeding. So typically one will not get the malignancy inside the polyp.
Absolutely. And if we don't diagnose that polyp correctly, we may miss the entire clinical picture of a PJ syndrome.
Absolutely. So the implications for screening, because everyone may not have the florid syndrome.
Yes. And one more pitfall in diagnosis of hematomatous polyps, especially PJ, is that if it is a smaller polyp, actually, we may not see these typical morphologic features. So, it's always better to, and that is what you do as well, that is always better to get a biggest of the polyps because that is the one which is likely to show all full-blown branching tree-like appearance. Smaller polyps may not have them. So it is one of the difficulties that we face in diagnosis. Okay, so this is a familial adenomatous polyposis syndrome, wherein we have a carpet of small adenomas all over in the colon and two synchronous adenocarcinomas arising on the background of familial adenomatous polyposis. All I want to tell you is one very interesting concept. As you know, familial adenomatous polyposis has a germline APC gene mutation, wherein every cell is at risk of development of malignancy. And when I say every cell, literally every gland in the colon can transform itself into an adenoma. And this is one condition where you can get literally single gland adenoma. And I'm highlighting these two glands, which are called as aberrant crypt foci, which are adenoma. Okay, this is a single gland adenoma, and this is how the colon develops numerous thousands and thousands of adenoma, which have a great propensity to develop into adenocarcinoma. Okay, fine. So great. So now I have covered the conventional adenoma, I covered the serrated lesions, and I covered hematomatous polyps, especially the PJ polyps. There are other hematomatous polyps in the GI tract as well. So last few of my slides, we do have, when I said we do have the non-neoplastic polyps, so there are other types of polyps where you have lymphoid polyps. Okay, so lymphoid polyps can be reactive lymphoid tissue, most commonly at the IC junction, which can lead to intersusception, or you can also have malignant lymphoid polyps. The common malignant lymphoid polyps are formed by mantle cell lymphoma and follicular lymphoma, wherein you would have multiple small polyps, and unless a biopsy is done, this diagnosis will not be made, and we as pathologists should be aware of these entities which occur in the colon. So this is one example of lymphomatoid polyposis, as it is called, which is nothing but multiple polypoid lesions as a result of involvement by mantle cell lymphoma. Now there are certain other polyps which
So
can.
just one point, madam. So this lymphomatoid or lymphomatous polyposis is very easy for the endoscopist to mistake it for an FAP sometimes, or an attenuated FAP, because again, it's like sometimes you could just have multiple polyps carpeting segments of the colon. So again, here it's the pathologist who really differentiates, because there are two diagnoses with vastly different outcomes.
Yeah, absolutely correct. Yes, yes. So malignant melanoma is one tumor which involves the GI tract in the form of multiple polyps in a metastatic setting. Then there are other syndromes, Cronkite-Canada syndrome. We have mucosal prolapse polyps, and this is one common condition. I think I should have included one of these cases. Maybe I can do this next time, which is a solitary rectal ulcer syndrome. And this is one lesion which endoscopically can resemble malignancy. It has hypertrophy of the muscularis mucosae with upward extension of the lamina propria, and the gland show architectural distortion. So this is one of the pitfalls that a pathologist can also overdiagnose mucosal prolapse or solitary rectal ulcer syndrome as malignancy because of the architectural irregularity. Then we have inflammatory polyps. Those occur in ulcerative colitis and Crohn's disease. And we have the polyps, which are due to the granulation tissue, due to edema, inflammatory cell infiltrate, and fibrosis. So one such example of inflammatory polyps, this is just an inflammatory exudate here, and that is causing edema as well as inflammation. It is causing an upward extension of the mucosa, and another polyp which is showing granulation tissue. So these are not true polyps. Then there are mesenchymal polyps, which are found by, say, any of the mesenchymal tumors, gastrointestinal stromal tumors, etc. So thank you. Now we can take some questions. Sorry for rushing towards the end, but if there are any pertinent questions, can we take them?
Yes, ma'am.
As I predicted, we do not have much time, only 5 minutes. So only, Sandeep, if you can filter some pertinent questions, please.
And most of the questions you have answered in your talk.
I see. Oh, great.
Ma'am, there are a few questions. Ma'am, it is basically for Prachi ma'am first. What will be the management of tubular adenoma if it's a adenocarcinoma in an adenomatoid polyp?
So again, there are some high-risk features. So one is a fragmented specimen is a very, very high-risk feature, I would say. So as far as possible, we try to take a single specimen. A piecemeal resection is always bad, especially in the case that madam showed that you got involvement of the base. So if we can get a good margin, especially if there's submucosal involvement, and if we can get a good 1000 microns margin, then an endoscopic resection is good enough. Otherwise, the patient needs to go for surgery, because anything beyond that, the risk of the presence of involved lymph nodes is very high.
Okay, ma'am, another question is management. If we report LAMN, low-grade appendicitis, bacillus neoplasm in appendectomy, what will be the management?
So for low grade, I think an appendicectomy, but we may not need a formal right hemicolectomy. Dr. Mukta can just reconfirm.
You know what, Sandeep? I mean, this in itself is a huge separate topic, not really relevant to today's talk. Can we take it later?
Okay,
yeah, it's not relevant to today's talk.
Madam,
And as I said, this in itself is a huge topic. So maybe we can discuss it later.
I don't think rest of the questions. I think Pooja, do you think any other questions are relevant which ma'am has not covered?
No, everything is covered.
Oh, great. Then thank you so much. Thank you.
Thank you, ma'am. Thank you so much.
I actually wanted to pose this slide to Prachi and just test her. Prachi, I just collected these 4 images. I'm very sure you would know which is which exactly without the history.
So the one on the right is an FAP.
This one.
Because it's like a very, very typical carpeted polyps that we see frequently.
Yeah.
The one on the left frequently mistaken for an FAP, but not. That is where the optical diagnosis comes into play, because pale polyps, if you could see, the polyps are typically pale, and the adenomas are typically going to be darker.
So what do you think this might turn out to be? Honestly, I do not know the answer to anything. I don't know what these are, except that I know that this is FAP, but I really do not know what this is and what.
So the left top is actually how typically fundic gland polyps look like in the stomach.
Okay.
That's a very typical appearance. And some of the hyperplastic polyposis syndrome, so small hyperplastic polyps are going to look pale.
Okay. Lymphoid polyps, can they be?
Lymphoid polyps can look like this. Inflammatory polyps also sometimes can look like this.
Okay.
But MLP, this is not how typically lymphomatous polyposis. This is not, the polyps are going to be more confluent.
Okay.
And the polyp which is below, left side below, they are like these, unstructured kind of a thing. So I don't know whether there's inflammatory pseudopolyps. Typically the types that you see with IBD, but the intervening mucosa is normal.
Right. Okay. And this one?
Which one, madam? Oh, the right bottom one. So the right bottom one again could be FAP.
Okay.
But I'm not sure.
Right.
It's just a carpet of polyps again.
So you would definitely want a histopath of all these cases, correct?
Yes, ma'am. So I didn't speak. Just I'll take a minute to speak on optical diagnosis of polyps.
Yes, please. We know little of it. It would be interesting.
Yeah. So there are 2. So the conventional endoscopy, the images that we are seeing is white light endoscopy. So typically now you have these high definition white light endoscopy, and most of the scopes today have these optical imaging features, which is called as a virtual chromoendoscopy, called as narrowband imaging. There are other companies that have other things. So what this gives is about a 70 to 140x magnification. And the virtual chromoendoscopy kind of filters some wavelength so that the surface mucosal and vascular pattern is seen better. So what it helps to see is the extremes are seen very easily and diagnosed easily. So it's easy to diagnose conventional hyperplastic polyps, and that's where the whole policy of remove and discard comes in, because the diagnostic accuracy is fairly good. Adenocarcinomas, typically frank tumors, diagnostic accuracy is very good. In between, to trained eyes, the diagnostic accuracy is decent. Now there's something called as confocal endomicroscopy, which has been on the horizon for many years, but it's a very expensive system, and that gives almost 1000x resolution, but it's not really mainstream as of yet. So optical diagnosis, yes, it helps in certain situations, but still there are things like the margin and depth of invasion and submucosal invasion, which only a pathologist can help us with.
Yeah, great. So that really completes the entire picture actually, when Dr. Prachi is sharing her expertise on endoscopy. and it gives us the perspective of where the pathology stands in the management of these polyps. Okay.
Just one word of advice is to talk to your endoscopist, because I mean, honestly, I think we are lucky in PMH that we have a good dialogue with our pathologists. But that helps, I think, both the sides to get a better idea about what the other person is looking for.
Yeah. Excellent. Thank you so much, Prachi. Thank you so much for your inputs. Sandeep,
Thank you so much, ma'am.
can we conclude?
Thanks, madam. Enjoyed your
Yes.
time. Thank you, Dr. Gujral.
Thank you, ma'am.
Thank you.
Thank you, ma'am.